Welcome to the lecture on Chapter 3, Public Health Data and Communications. In this chapter, we will explore how health information is collected, compiled, and presented, how it is perceived, combined, and used to make decisions in the arena of health communications. By the end of the chapter, our learning objectives include to identify 6 basic types of public health data, explain the meaning, use, and limitations of the infant mortality rate and life expectancy measurements, explain the meanings and uses of HALES and DALYs, identify criteria for evaluating the quality of information presented on a website, explain ways that perceptions affect how people interpret information, explain the roles of probabilities, utilities, and the timings of events in combining public health data, explain the basic principles for the construction of decision trees and their uses, explain how attitudes such as risk-taking attitudes may affect decision-making, identify 3 different approaches to clinical decision-making and their advantages and disadvantages. So in your textbook, there are some questions or issues that your chapter addresses. Based on that, some questions to ask are, what is the scope of health communications? Where do public health data come from? How is public health information compiled to measure the health of a population? How can we evaluate the display and quality of the presentation of health information? What factors affect how we perceive public health information? What type of information needs to be combined to make health decisions? What other data needs to be included in decision making? How do we utilize the information to make health decisions? How can we use health information to make healthcare decisions? So what is the scope of health communications? Health communications deals with the method for collecting, compiling, and presenting health information. It addresses how we perceive, combine, and use information to make decisions. Health communication is about information from its collection to its use. This diagram represents the public health data, health communication, and the flow of information, which ends with decision making. So we collect, compile information, present information, we perceive information based on some factors, and then combine information to make a health decision, and finally we utilize this information to make health decisions. So where do public health data come from? Public health data are collected in a wide variety of ways. These methods are often referred to as public health surveillance or just surveillance. Data from public health surveillances are collected, published, and distributed without identifying specific individuals. Data of this type come from a growing variety of sources. It is helpful, however, to classify these sources according to the way they are collected. Based on the way the data are collected, we look at 7 S's of quantitative sources of public health surveillance data. These are the sources or the type of the data. So first one is single case or small series. Here, case reports of one or small number of cases are studied, such as number of case reports of people with SARS, anthrax, mad cow disease, and other new diseases. So the use of single case or small series is to allow to new disease or resistant disease. They alert to potential spread beyond the initial area. It is useful for dramatic, unusual, and new conditions. Requires alert clinicians and rapid ability to disseminate information. Right now, case reports of coronavirus is kind of like a single case or small series. Initially, when it started, we had Just the knowledge of the disease, and case reports help us to identify more about the disease. Moving on to the next S is vital statistics or statistics. So vital statistics include birth, death, marriage data, divorce rates, and reporting of key communicable and specially selected non-communicable diseases. These are called notifiable diseases. Like you have elder abuse, child abuse, elevated lead levels, these are all notifiable. And certain communicable diseases like chlamydia or gonorrhea, these are notifiable diseases. And it is required by law. Sometimes penalties imposed for non-compliance. So births and deaths, key to defining leading causes of disease. So the major advantages are vital statistics, very complete because of social and financial consequences. Reportable disease often relies on institutional reporting rather than individual clinicians. So there are frequent delays in reporting data. Moving on to the next S, that is surveying or sampling. It is a little more on a wider scale. So there are national health, nutrition, and examination surveys or behavioral risk factor surveillance system. And there are other surveillance systems as well. So what are the main uses? They are drawing conclusions about overall population and subgroups from representative samples. So these registries attempt to include all those with the disease in order to be representative of the population. So major advantages are well-conducted surveys allow inferences to be drawn about larger population. Disadvantages, frequent delays in reporting data, and it's difficult to include all potential patients in disease registries. Another type of S or quantitative data is self-reporting. That is, you report that you have a disease or adverse effect of a medication. For example, adverse effect monitoring of drugs and vaccines. So patients are encouraged to fill out online reports of adverse events associated with the use of drugs and vaccines through a spontaneous reporting system. So that is a self-reporting. It may help identify unrecognized or unusual events. Next is sentinel monitoring. That is influenza monitoring to identify start of an outbreak or changes in virus type. It can be used for real-time monitoring, requires considerable knowledge of patterns of disease and uses of services to develop. So early warnings, warning of previously unrecognized events. So we have in Corona too, there is sentinel monitoring of how this outbreak has spread from one region to another region, and how is the patterns varying, is how the different races are affected, or how the diseases are affecting immunocompromised or even children. So we are continuously monitoring. That is sentinel monitoring. So one example is influenza monitoring to identify start of outbreak and changes in the virus type. So it can be used for real-time monitoring. Moving on to syndromic surveillance. That is, an example is use of symptom patterns. Example, headache, cough, fever, or GI symptoms. And plus increased sales of over-the-counter drugs to raise alert of possible new or increased disease. One example is data on diarrhea, nausea, and vomiting are collected in the emergency room, and data on purchases of over-the-counter medications to treat diarrhea, nausea, and vomiting are monitored through pharmacy sales. So that is syndromic surveillance. So you're looking at the symptom patterns and you're assessing what are some over-the-counter medications, or how much of medications are bought in the over-the-counter, or how many cases were there in the emergency room. So major use is it is able to detect unexpected and subtle changes, such as bioterrorism or new epidemic producing or commonly occurring symptoms. Major advantages may be used for early warning even when no disease is diagnosed. Does not provide diagnosis and may have false positive is a one disadvantage. Again, looking back at coronavirus, we can identify certain symptom patterns. Okay, based on the symptom patterns, you are identifying, okay, is that the symptoms, or is it different? Is it changing? So it's based on the symptom patterns you're looking at collecting data. That is known as syndromic surveillance. Next is through social media. Right now, data on outbreaks using keywords from social media detect and monitor course of influenza epidemic. Other advantages are potential for immediate data obtained from a large number of individuals. Accuracy and precision of the data for early and ongoing surveillance needs to be established before using the data from social media. So data from different sources are being combined to create integrated health data systems or databases that can be rapidly and flexibly used by computers to address a wide range of questions. Next question is, how is public health information compiled to measure the health of a population? So measurements that summarize the health of populations are called population health status measures. In the 1900s, two of the measurements became standard for summarizing the health status of population. That is the infant mortality rate and life expectancy. So these measurements basically rely on death and birth certificate data, as well as the census data. So infant mortality rate estimates the rate of death in the first year of life. So infant mortality, it includes all deaths during the first year of life in the numerator, divided by all live births during the year in the denominator. Moving on to life expectancy. Life expectancy has been used to measure the overall death experience of the population, incorporating the probability of dying at each year of life. For example, if life expectancy at birth in a developed country is 80, that does not mean that a person cannot live beyond the age of 80. It's a snapshot of a population incorporating the probability of dying at each age of life in a particular year. So life expectancy helps us to make comparisons between countries, compare large groups such as males and females within a country, and to measure changes over time. For example, in 1900s, the life expectancy may have been only 50 years, but now the life expectancy at birth in a developed country is 80 years. So the life expectancy cannot be used to accurately predict future lifespan. Because accurate prediction requires death rates at all ages to remain the same in future years. We have seen increases in life expectancy in most countries over the last centuries. And there can be a substantial decline in life expectancy in the coming years in the United States as a result of obesity and opioid epidemics. So life expectancy reflects the impact of dying, but not the impact of disabilities. So when considering the health status of a population in the 21st century, we need to consider disability as well as death. And what is under 5 mortality? Even though infant mortality tell us how many infants are dying within the first year of life, it was found that children were still dying prematurely who are under the age of 5. There were deaths or mortality among children aged 2 to 5 from malnutrition, all the new infectious diseases, HIV and AIDS. So now we are looking at under 5 mortality, number of children who are dying under the age of 5. So under 5 mortality is now the standard health status measure which is used by WHO to summarize the health of children. Moving on to HALE or Health Adjusted Life Expectancy. HALE measurement starts with life expectancy and then incorporates the measurements of quality of health. So it includes the measures of morbidity and mortality. It combines life expectancy with measures of the quality of health. WHO uses it as an overall measurement of population health status. So what are these components that they include to calculate the quality of health? So they have checked the mobility, the ability to walk without assistance, cognition, or the mental function, which includes memory, self-care, activities of daily living, where either is able to do the activities of daily living, including dressing, eating, bathing, and the use of the toilet, and pain, regular pain that limits functions, and then checks mood, alteration in mood that limits function, or sensory organ function, impairment in vision or hearing that impairs functions. So from these measurements, an overall quality of health score is obtained. So a quality of health measurement of 90% indicates that the average person in the country loses 10% of his or her full health over his or her lifetime to one or more disabilities. So the quality of health measurement is multiplied by the life expectancy at birth to obtain the HALE. Thus, a country that has achieved life expectancy at birth of 80 years and an overall quality of health score of 90% can claim a HALE of 80 into 0.90, which makes about 72. Table 3.2 displays WHO data on life expectancy at birth and HALEs for a variety of large countries. So the United States, the HALE is 69.1. And United Kingdom, it is 71.4. Japan has a more life expectancy, which is 83.7, and HALE as 74.9. So we already saw that under 5 mortality and HALE are used by WHO as a standard measures reflecting child health and the overall health of a population. Another measure that is used to measure the health of a population is disability adjusted life year. So disability adjusted life years are designed to examine the impacts that specific diseases and risk factors have on populations, as well as provide an overall measure of population health status. So what are the disabilities that it combines? Combine data for communicable diseases or non-communicable diseases or injuries. And data is also available on specific diseases and risk factors such as impact of cigarette smoking, alcohol use, and depression. So when you calculate DALYs or disability adjusted life years in the United States, per 1,000 population, the disability adjusted life year lost due to communicable disease is 18, and DALYs lost due to non-communicable diseases is 244 per 1,000 people. And DALYs lost due to injuries or unintentional injuries are 27. And Global Burden of Disease Project has produced a number of important conclusions using disability adjusted life year, including depression is a major contributor to the most nations' DALYs, and it may become the #1 contributor in the next few decades in developing as well as developed countries. So table 3.2 emphasizes the life expectancy and the health adjusted life expectancy for a range of large countries. We saw that in the United States it is 69.1. So that is the health adjusted life expectancy. That is life expectancy into the quality of health, which makes it 69.1 years. And disability adjusted life years lost by disease categories. We saw that disability adjusted life years help us to examine the impacts that specific diseases and risk factors have on populations. It provides an overall measure of population health status. So it allows comparisons between countries or within countries over time based not only on overall summary numbers such as life expectancy and health, but also on specific diseases and risk factors. So based on the disability adjusted life years, we can identify the population health status of a population. So it is calculated per 1,000 population. So about in the United States, 289 disability adjusted life years per 1,000 population is lost because of specific diseases. Let's look at how can we evaluate the display and quality of the presentation. So there are some quality standards for health information on the internet. So one is overall site quality. So is the purpose of the site clear? Is the site easy to navigate? Are the site sponsors clearly identified? Are advertising and sales separated from health information? Moving on to authors. Are the authors of the information clearly identified? Do the authors have health credentials? Is contact information provided? Next, we have to look at the information. Does the site get us information from reliable resources? Is the information useful and easy to understand? Is it easy to tell the difference between fact and opinion? Then look at the relevance. Are there answers to your specific questions? Timeliness. Can you tell when the information was written? Is it current? And links. Do the internal links work? Are there links to related sites for more information? And privacy. Is your privacy protected? Can you search for information without providing information about yourself? These are data obtained from American Public Health Association, the criteria for assessing the quality of health information on the internet. And public health information is often presented as graphics. So graphics create a picture in our mind of what is going on. So graphical representations can accurately inform, but they can also mislead us in a wide variety of ways. So graphics are primarily used to display and examine possible relationships or associations between two variables. There are three types of basic forms of graphical presentation. One is XY graphics, another one is geometric graphics or bar diagrams, and the third one is the pie charts. So looking at the XY graphics, or otherwise known as line graphs, it is a popular and a very attractive method for presenting large amounts of information. So it has the y-axis and an x-axis. The x-axis is the horizontal scale and the y-axis is the vertical scale. So these are useful for displaying possible associations, or what are often called correlations. So if they looking at the coronary artery disease, we saw that in 2000 the number is between 500 and 600 per 100,000 population, and the rate has been increasing from 2005 to 2010 to 2015. This trend is slowly increasing. But looking at the cancer, we see that the rate has been increasing more rapidly, and from 2000 to 2015. Again, there's a trend for other diseases, and look at the stroke, the number is going down from 2000 to 2015. So XY is helpful to give an association or correlation between two variables. Here we're looking at deaths per 100,000 population, and at different years, how was the trend? So it is helpful as to identify what is the trend of deaths because of illnesses during those years. Looking at this diagram, it is actually we cut off at 350. It is the same diagram when we cut it off at 350 and put a little bar like this. It's called cutting off. Okay, so if you cut off the death rates at 350 per 100,000 instead of 0, the apparent increases in cancer rates is magnified. We may feel that the rate of cancer death is increasing very rapidly and far more rapidly than in figure 3.2. So based on who represents the data, we can actually make it appear more vivid, and so we need to have some amount of critique when you look at graphics. Another form of graphic representation is using column charts or bar charts. So in this case, again, we are looking at each year in 2000 number of people who died, deaths per 100,000 population. Then we're looking at 2005, 2010, and 2015, the people who died because of coronary heart disease in those years. It is represented using a bar diagram. It means maybe the same line diagrams can be represented using a bar diagrams too. And based on the cancer, what was the number of deaths in 2000, 2005, 2010, and 2015. And again, the stroke and other. The column graphics or bar diagrams are often very good ways to display information, especially when there are only a limited number of potential categories of information, such as coronary heart disease, cancer, stroke, and other. Next, moving on to other type of diagram. So pie charts or percentage charts display the percentage of the total that is associated with each of the components that make up the whole at one point in a time. For example, in this particular example, in country C in 2015, these are the causes of deaths. So coronary heart disease seem to be having higher amount of deaths, and followed by cancer and other, and then stroke being less a less contributor to the number of deaths in 2015. Another example can be say like, okay, when you are looking at a particular research study, we can say that, okay, 95% of the sample was male and other 5% was female. So we can represent it by 95% being covered by one color and the other being covered by, for the females, a smaller color. So that is another example for pie chart. Then looking at the quality standards for the health information on the internet, as we said earlier, we looked at overall site quality, the authors, the information. When we look at the relevance, the timeliness, the links, and the privacy information. So let's look at what factors affect how we perceive public health information. Even though we have this wonderful data collected and it is wonderfully displayed, how we perceive the data depends on some effects or some factors. So there are three types of effects that can greatly influence our perception of potential harms and benefits. So one is dread effect. That is, hazards that easily produce very visual and feared consequences are considered more potentially harmful. For example, We fear shark attacks more than drowning in a swimming pool because of the dread effect. Next is unfamiliarity effect. That is, hazards we lack experience with may elicit more fear. Or other way too, so knowing a friend or relative who died of lung cancer may influence how we perceive the information on the hazards of smoking. And another example is, even though the data says the danger of sun exposure is high, and the harm is higher, we don't fear the danger of sun exposure, and we fear the danger of food irradiation as higher, even though the data indicate that the degree of harm is the other way around. Next, moving on to uncontrollability effect. That is, hazards out of control perceived as more threatening. So hazards out of our control perceived as more threatening is the uncontrollability effect. For example, automobile collisions, for instance, are often seen as less hazardous than commercial airplane crashes, despite the fact that statistics show that commercial air travel is far safer than travel by automobile. So let's look at what type of information needs to be combined to make health decisions. First is how likely. What is the probability or chance that the particular outcome will occur? For example, what is the percentage of success with a chemotherapy? What is the probability of success? So if there's an 80% chance of cure with a particular chemotherapy, it is equal to 0.80 probability that the treatment is a success. So it is 80% is equivalent to 0.80 probability. So percentages ranges from 0 to 100 and probabilities ranges from 0 to 1. Next is how important is it? So what is the value or importance we place on a good or bad outcomes? It is measured using utility scale or expected utility. So in order to measure utility, we're looking at a range. Okay, full health is 100% utility, but death is, or immediate death, gets a score of 0 always. So on the utility scale, there is nothing worse than immediate death. And based on how a person perceives or identify that a particular outcome is important to him, a utility score would differ. So it measures and compares the value or importance that different people place on different outcomes. So if there is 100 full health, it gets 100% utility scale, and immediate death gets a 0% utility. So if there are two interventions, okay, there are some, how do we select one intervention over another intervention? That is using decision trees. We are looking at some expected utilities, and expected utilities are displayed using graphical methods called decision trees. So in decision trees, it is made up of two types of nodes. One is a choice node and another one is a chance node. Choice node is represented using a square box, and a chance node is represented using a circle. So we have a choice between intervention 1 or intervention 2. And based on we take what intervention 1, there's a chance that this may be the outcome, or this may be the outcome, or there can be another outcome. There can be an outcome 1, outcome 2, or outcome 3. So we have a choice between 2 interventions. That's our choice. And based on the chance node, there can be 3 types. Okay? So in decision trees, square represents for choice and circle represents the chance nodes. Now let's look at how we utilize this chance nodes, choice nodes, or decision tree to make a health decision. For example, we are looking at intervention 1. Okay, we have 2 choice, intervention 1 and intervention 2. This is the choice node. And if we take intervention 1, there's a chance that there's a probability of 0.80 to have cure. There's a probability of 0.20 to die. Okay, there's a 0.80 probability that it might lead to cure, or there's a probability 0.20 probability that might die. So it means 20% die and 80% chance that the patient survives. And on intervention 2, again, there's a chance node, 0.70 probability that maybe it can lead to cure, and 0.20% that the patient can have permanent blindness because of the treatment. And there's a 0.10 chance or 0.10 probability that they would die. So based on these interventions, we have to look at what is the expected utility based on these interventions. So how do we look at expected utility? So now we're looking at cure, at the probability of 0.80 into utility. So we said that utility ranges from 0 to 1. So the utility 1 or 100% is that we get an expected utility of 0.80. 0.80 into 1 makes it 0.80. And then die, probability of 0.20 into 0. So when you die, the utility is 0. Immediate death is 0. So that makes it 0. And then you calculate the total expected utility of intervention 1. That is 0.80. And we're looking at how we looked at intervention 2. There's a 0.70 chance and there's a utility of 0.1, 0.70. And here, blindness 0.20. Here we see that there's a utility of 0.5. What does that mean by? That means that on an average, some people regard blindness as having a utility of about 0.5. It means that some people say that I can live with blindness. Okay, if it has the ability to cure me, I'm able to live with being blind. So I agree that this is how much value I'm giving to blindness. So 0.5. Some people say I have a high utility, that is 0.8. That means I don't care even if I'm blind. By 0.8, even if it causes blindness, I can survive, I can learn more, and I will be able to live with it. Okay, so it gives us the utility is more at 0.8. It differs, your score would differ. And some might rate it as 0.2. They said, no, I cannot live with being blind. So I have a lower range of utility for that, being blind. So based on that, my expected utility would vary. But currently for this intervention number 2, the cure 0.7, the expected utility is 0.7. Based on the current utility of 0.5, it becomes 0.10, and 0.10 into 0 makes it 0. So there's an expected utility of 0.80. And now we have to make the decision. Okay, now we saw that both of the expected utility of intervention 1 and intervention 2 was the same. So now we look at what if he had an increased utility of 0.8. He said, I don't care even if I have blindness, I have a 0.70 chance of curing it, I would take it. So that the expected utility has increased, it becomes 0.16. And now the overall expected utility of intervention 2 increases by 0.06. Other one was 0.80 and 0.80 in the previous figure. Now we see that when you attribute more utility to blindness, expected utility increases. That means intervention 2 may be favored than intervention 1. Now we look at if the utility of blindness was equal to 0.2. Here I'm saying that I cannot live with blindness. I have a very poor utility for that. Okay, so I'm giving us only a score of 0.2. That means I have only a 0.04 expected utility, and my overall expected utility will go down to 0.74. So in this case, I would take intervention 1 over intervention 2. So when a factor such as utility we place on blindness produces a change in the recommended choice of intervention, we say that the decision analysis is sensitive to the factor such as blindness. Now we will look at what other data needs to be included in decision making. So first question is how soon? When on average will the particular outcome happen if it is going to happen? Because we are doing this particular intervention number 1, so when is this particular outcome going to happen, or when is this cure going to happen? Now we will take into account discounting. Discounting is a quantitative process in which we give greater emphasis or weight to events that are expected to occur in the immediate future compared to events that are expected to occur in the distant future. So if there are immediate future outcomes, we give more emphasis or weight to that process. So that is known as discounting. Then we'll look at what are the characteristics of the decision maker that influence decision making. So a decision maker may be an individual, health professional, an organization such as a non-profit or a corporation, or a governmental agency. So based on the characteristics of the decision maker itself, a decision would be different. Next important question is how do we utilize information to make health decisions? Here comes a risk-taking attitude. An attitude that favors taking actions or avoiding action that differ from the recommendations given. There are two main key questions that we need to ask here. How do our risk-taking attitudes affect the way we make decisions? How do we incorporate information into our decisions? Most of us are risk takers when conditions are intolerable, and risk avoiders when conditions are tolerable. And there's something else that plays an important effect too, that is called certainty effect. So certainty effect is if there is a tolerable situation and they do not want to take any chances of being reduced to a lower, perhaps intolerable utility, and they want to guarantee a tolerable level of health, we consider one intervention over the other. So that is known as a certainty effect. We know that if you take this intervention, our utility become higher. So we take that effect. That is known as a certainty effect. Another effect is called the long shot effect. So even when the quality of life is bad, most people are willing to take the chances and go for it. So this risk-taking behavior can be called the long shot effect. Okay, so based on our risk-taking attitudes, we make decisions and incorporate informations into our decisions. So how can we make use of health information to make healthcare decisions? There are three main approaches. One is informed decision. Here the clinician has all the essential information and can make decisions that are in the patient's best interest. And here the clinician provides patient with only the information that the clinician believes that patient needs to know. That is the informed decision. Clinician has all the information, but he makes a decision and he tells that, okay, this is what you need to know and this is what you're going to do. That is one approach of using the health information. That is informed decision. Another one is informed consent. Here patient needs to give their permission before intervention. That is informed consent. So here the patients are giving the permission or consent before major interventions such as surgery, radiations, or chemotherapy. Here, informed consent means that individuals have the right to know what will be done, why it will be done, and what are the known benefits and harms are, and patients have the right to ask questions, including inquiring about the availability of other options. So informed consent does not mean that all possible options are presented to the patient, but it does imply that a clinician has made a recommendation for a specific intervention. That is informed consent. Third level of decision, or third type of decision making, is shared decision making. In shared decision making, clinician provides information to the patient with which patient can make a decision. So here, a clinician uses a decision making approach in which the clinician informs the patient of all available options, including the harms and the benefits for each option, and does not make a recommendation. So the difference between informed consent and shared decision making is, in informed consent, the clinician has made the recommendation and we are getting the consent from the patient to carry on that intervention. For example, I want to take HIV/AIDS test for blood, and I'm getting an informed consent from the patient for doing an HIV blood testing on the patient. In shared decision making, the patient makes a decision. I'm saying I don't need the vaccination for hepatitis, or that a clinician is giving all the information to the patient and the patient makes a decision of her treatment. I'm saying, no, I don't want the hepatitis B vaccination for me. So that is a shared decision making. So using this approach of shared decision making, clinicians are not required to provide recommendations on specific intervention, though patients are free to ask for a clinician's opinion.